Hello again. I will like to present in the second talk now practical approaches to manage the invasive fungal infection. Um, and uh, again, I would like to thank Professor Mottaba to inviting me for these lectures. So in this talk, I will be discussing the approaches to manage the fungal infection in high-risk pediatric patients. Um, the limit of my talk will be today what is the population which is at risk, epidemiology of fungal infection, risk factor and pathogenesis, diagnosis and optimal treatment strategy. So as it is important to know that there is a substantial differences in management of invasive fungal infection in pediatric patients compared to adult patients because of the differences in underlying diseases and comorbidities, host response, and immune reconstitution after chemotherapy. So the risk at population, mainly they are neonates, especially the premature, very low birth weight babies, patient with long-term PICU stay, and immunosuppressed transplant population, malignancy, graft versus host disease, and patient with congenital immunodeficiencies. The incidence in pediatric patient is variable, and there is not much data. The most of data which is available is in transplant patient and in neonates. There is an increasing pool of immunosuppressed patient and use of newer and more potent immunosuppressive agents, increased pressure of antibiotic, and increased survival of premature neonates that is contributing to increasing incidence of fungal infection in the last decades. And incidence varies from center to center, and also it depends upon the patient population. This is the slide which shows the incidence of a fungal infection in solid organ transplant patient and in neonates and in hematology malignancy. The important thing to note in this slide is that Candida infection is mainly associated with neonates and in intensive care unit and liver and kidney transplant, whereas heart, lung, and hematology malignancy, they have high rate of invasive mold infection. This is the surveillance study in the UK to see the incidence of fungal infection, and it varies from 2.4 per thousand neonatal admission to 18.8, highest being in the low birth weight baby. The epidemiology of invasive fungal infection, there are two main types: invasive candidiasis and invasive aspergillosis. However, we have seen changing trend in the transplant population. This is the Transnet data, which shows that in solid organ transplant, there is a shift towards more of invasive mold infection and another non-candidized infection. However, in pediatric liver transplant and in intensive care unit, we have not seen much changes. The other infections are very rare in pediatric patient population. The type of candida which is most predominantly causes the infection, Candida parapsilosis is dominating in neonates, and Candida albicans and parapsilosis and Caglabrata in older children. This is the epidemiology data from our hospital, and if you see in that again, the Candida albicans being the highest, and second common is Candida parapsilosis. It is very important to know the risk factors. What are the risk factors for the various patient population who are going to develop the infection? Patient in PICU and in a NICU, the invasive devices and invasive therapies for long term are high risk factors, and some of the medications, and in transplant population and hematology malignancy, and patient with underlying congenital immunodeficiencies, and they have the immature immune defense, colonization with the fungus, and immunosuppression are very important factors. And in transplant population, the surgical factors are the very important. In patient Now, donor factors are becoming more important as well, especially cadaveric donors who are infected with fungus, they can transmit to the transplant patient. The second most important aspect is the Candida species. Different species can have dominant risk factors. For example, Candida parapsilosis, which is common in neonates, H2 antagonist, and Candida glabrata is associated more with the exposure to fluconazole and with the bowel complications. Now, the another risk factors, what we have tried to analyze in our patient population, especially in our liver transplant recipient, the variables independently associated with fungal infections were pre-transfungal colonization and retransplantation, more antibiotic use, and some viral infection, especially EBV. So to understand how the patient acquired Candida, we all of know that these are the normal endogenous flora. Antibiotic selection pressure cause the overgrowth of Candida species in the bowel. Any insult or injury to the gut will cause the translocation. They can seed into central venous catheter and can cause the disease. The most important factor they will go for causes the candidemia, and the spectrum of disease can vary from mucosal candidiasis to disseminated disease. And dissemination usually happen here when this patient might have persistent fungemia because of inadequate antifungal therapy or antifungal doses, or delayed in diagnosis, or delay in removing the vascular catheters. And most common, sometimes this is a rare complication, is hepatic candidiasis. So the second most common fungal infection is invasive aspergillosis. Although it is rare in children, most common patient or risk factor on the other hand is the patient with hematology, malignancy, and bone marrow transplant, and chronic granulomatous disease patient. And it's very rare in solid organ transplant recipient. Other risk factors are persistent neutropenia, long-term corticosteroid therapy, and patient with ECMO. So this is the slide which is I like to show the mortality associated with invasive aspergillosis, and it can vary from 20 to 100%, although we can see the incidence is very low for most of the patients. Invasive aspergillosis, the most common manifestation is pulmonary in pediatric patient. However, in liver transplant, we have seen extrapulmonary, and most common manifestation was the brain abscess. Aspergillus fumigatus is most common species. The sign symptoms, they can vary, depends upon the patient population. Immunosuppressed patient, they can be very non-specific symptoms. Hemoptysis and infarction, cavitating lesion, they are secondary to because of the angiotropic nature of the aspergillosis. For early diagnosis, we should do the CT scan and biomarkers. So if the patient has got ARDS, it is difficult to interpret the scan. Halo and ear crescent signs are typical or classical signs of aspergillosis, but they are less common in younger children, predominantly present with nodular lesions. Other lesions are segmental and multilobar consolidation, perihilar, infiltrate, cavitating nodules, and very rarely you can see pleural effusion. Now, from diagnosis of invasive fungal infection is very challenging. The old method or the cultures, microscopy, histology, and imaging, most of centers are using, but in the current era we are using more of now invasive fungal biomarkers, and also recommended in some of the American and European guidelines. And I'll talk a little bit about the molecular test. So limitation of classical diagnostic tests are especially the cultures, they rarely become positive and highly time consuming, usually negative because of the antifungal prophylaxis, and they are very low, sensitivity is very low. Whereas histology is very specific, but it requires invasive procedure. And even when we recognize the lesion, or it's not always easy to do the invasive procedure. It is always important for early diagnosis to do the diagnostic aspirate if you suspect the lesion in brain, liver, or any other organ. So biomarkers now are one of the important non-invasive way of diagnosing the fungal infection. That there are various biomarkers which has been tested in the last few years. Serological test, menin, anti-menin antibodies, but they are not widely used because of low sensitivity and specificity. And the Candida specific metabolites, again, they don't detect some of the species like Candida glabrata, which is highly prevalent in some of the population. That these two biomarkers, beta-G-glucan and galactomannan, are now highly and widely used in various centers for diagnosis of Candida and Aspergillus infection. So the beta-D-glucan, it is a pan-fungal biomarker. It is a cell wall component of wide variety of fungi. And however, it doesn't detect zygomycetes or cryptococcus. We can detect in serum, it is not validated in CSF and BAL, but we can use for detection. It doesn't get affected by antifungal use, and we have to have the cutoff value which can vary from different population. False positive we can find in presence of dialysis membrane with albumin and immunoglobulin infusion, and in presence of some beta-lactam antibiotics. Galactomannan, on the other hand, is very specific marker for Aspergillus investigation. It is a polysaccharide which is only released by growing Aspergillus hyphae. It is less sensitive in serum and CSF, but it is highly sensitive and specific in bronchoalveolar lavage. So I will recommend that when patient you suspect with pulmonary aspergillosis, we should always test that in bulk. Now it gets affected by use of antifungal. It can reduce or can become false negative, whereas cutoff value is variable in BAL and in serum. Again, it can be affected by false positive by tazocin or by another antibiotics. So in the specificity and sensitivity wise, various meta-analysis studies have shown that sensitivity is low. However, the negative predictive value is very high. And similarly for galactomannan, the negative predictive value is very high. And the negative predictive value nowadays, we can use it as a marker for stopping the antifungals. However, the diagnosis, the sensitivity is low. So if you see the beta-D-glucan in the various studies and literature, it has been shown useful marker for diagnosis in solid organ transplant recipient and ITU setting. On the other hand, galactomannan is very useful in hem-onc patient which have got very high incidence of invasive aspergillosis. So molecular methods, there are a number of molecular tests in the last 5 years. The most important test is 18S ribosomal RNA, which is detects the fungal gene, and PCR assay mainly developed to detect Candida and Aspergillus with the very high negative predictive value of more than 90%. There are a number of commercial assays available. If you see all of them, they detect up to 15 species of fungi, or maximum they can detect up to 75 fungi. However, despite the increasing application of fungal detection, molecular tests still are not accepted as a diagnostic criteria to define invasive fungal infection. They have a number of limitations because of lack of standardization, and they show a wide range of test sensitivity and specificity. There's a lack of validation in the laboratories, and environmental contamination is a big challenge. And there are also limited or controversial outcome data. A benefit of routine diagnosis and cost effectiveness is not assessed. So, however, in the lab now, that we increasingly using them with a more validation results available. Antifungal therapy has to be rationalized based on in pediatric patients based on their um, age dependency, functional characteristics of hepatic and uh, renal function with regard to both metabolism and elimination of the drug, and also the distribution of the antifungal because of the body surface area and body weight, and that is because of dramatic change from birth to adolescence. Now, everybody, this is the question: what should be the best antifungal? So it has to be safe. Should have the least nephrotoxicity, hepatotoxic, and reduce interaction with immunosuppressive agents. And this should be the antifungal which pharmacokinetics and pharmacodynamics are well described for population. It should be easy to administer. That means they has both IV and oral preparation. And most importantly, they should be licensed for pediatric population. In the last 2 decades, we have increasing armamentarium of antifungals, and the most important one which are licensed for the pediatric use are liposomal amphotericin. These are the echinocandin, which are safe with the less side effects. Fluconazole has less side effects. Voriconazole and posaconazole, they are only used for proven diagnosis of invasive aspergillosis because of their highly hepatotoxic and has number of side effects. Now we have got the newer antifungal, which is azole group, and this is the new isobuconazole, which is now widely used in hematology patient for treatment of invasive aspergillosis and mucormycosis. Now, what is the optimal antifungal strategy? The most important way of preventing the infection is to give the prophylaxis, and that's most widely used in different population. It should be a targeted antifungal therapy. That means it has to be based on the risk factors, and we can widely used in pediatric patient are fluconazole, micafungin, and liposomal amphotericin B. Then we have empirical and preemptive therapy and proven therapy for proven fungal infection, and we can use all licensed drug depending upon the type of infection. So there is a advantage and disadvantage with prophylaxis. The pros for antifungal prophylaxis are it has reduced the rate of infection, it has reduces the rate of colonization and reduces the mortality after candidemia. But the cons are that the fungal epidemiology shift. We have seen that with increasing use of fluconazole has caused the more shift towards Candida glabrata and antifungal resistance, and there is no benefit on mortality rate that has been proven fact in our liver transplant population. Now we have done the study where we have seen universal antifungal prophylaxis versus targeted prophylaxis. Targeted means that we use the antifungal to target whether risk factors for aspergillus or for non-candida albicans. And we have seen significant reduction in fungal infection from 40 to 10% and invasive fungal infection 20 to 2%. The treatment of candidemia, I like to highlight some of the facts because this is the most common infection you will see in your wards and ITU setting. It is the fourth most common cause of nosocomial bloodstream infection. And we always ask to do the echo and eye exam in these patients to rule out endocarditis and endophthalmitis, which can be a manifestation of disseminated disease or candidemia. And it is important to remove the CVC in early stages and should repeat the blood culture and antifungal treatment according to guidelines. Echinocandins are the first line, and in pediatric patient, micafungin is a licensed drug. An alternative are lipid formulation of liposomal amphotericin B and azoles. Now, voriconazole is the first line drug for the treatment of invasive aspergillosis. However, there is limited data in pediatric patient. We do use always in patient with invasive aspergillosis, but there are a number of side effects. It can be associated with hepatotoxicity and nephrotoxicity. It has got decreased bioavailability with fat, and it requires anti-stomach. It interacts with immunosuppressive agent. The biggest drawback is that you always have to do the therapeutic drug monitoring to make sure that your immunosuppressive level or voriconazole level should be adequate. Now, in the last, I will like to present the two cases from our center. The case scenario one, this is a 15-year-old male who has Langerhans cell histiocytosis. He had BMT, had multiple courses of antifungal, antibiotic, antivirals. After his BMD, he has the lung biopsy to see the evidence of LCH and or fungal infection were ruled out. 6 months later, this patient developed bone marrow after bone marrow transplant, liver failure, and he ended up getting the liver transplantation. Post liver transplantation, this is the patient who fulfilled the criteria for high risk for invasive aspergillosis. We started him on high dose antifungal 5 milligram per kilogram, and patient stayed on high immunosuppression as well. However, despite this high dose antifungal, day 18, he developed a multiple cutaneous lesion. He had no fever at that time. Patient was in high dependency unit. He had pancytopenia with neutrophil count of less than 100. There were mildly abnormal LFTs and RFTs. Culture, everything stayed negative. So we'll assume what your diagnosis could be at that point. We will think that, yeah, it could be bacterial, it could be viral, it could be drug rash. That's what the most common thing come to your mind, or it could be none of above. The first thing what you will do is that we should do the skin biopsy and send it to histology and culture. And it was very helpful to see early diagnosis that it was studied with fungal hyphae, which was specific for aspergillosis, dichotomous branching with the septate hyphae, and culture also grew Aspergillus fumigatus after 7 days. So this is the patient we diagnosed early because of the skin biopsy. Then we started him on treatment, added the voriconazole along with ambisome, and despite the more than 3 weeks of treatment, there's a worsening skin lesion. And also we gave him leukocyte infusion. There's a resolution of skin lesion and negative for mode after 4 weeks. However, 3 months after, this patient has relapse of underlying disease. This patient, I think what treated him is immunomodulation. So that's what we have to think about in some of the patient. This is the case scenario 2, the 14-year-old patient who presented multi-organ failure secondary to the Staph aureus. He progressed to the acute liver failure 2 weeks after admission. He had liver transplant, and first 11 months of ICU stay was complicated by bowel perforation, and then pancreatitis, intra-abdominal bleed, renal failure, he was dialysis dependent, and other complication being splenic infarct. He has multiple viral infections and colonized with a number of multi-drug resistant bacteria. Only bacteremia he had with Enterococcus faecium. In the Candida was positive in his abdominal drain fluid, but not positive on anywhere else. He developed HLH and pancytopenia requiring GCCF and multiple transfusion and blood products, and he was treated with steroids and immunoglobulins. He has persistent thrombocytopenia, which was requiring daily transfusion. He stayed in PICU for more than 1 year, and you can see here his inflammatory markers, which were up and down during his stay, kind of white cell count. And at the end of 1 year, he became very neutropenic and pancytopenic. And this is our biomarker investigation of this patient for 1 year. If you see in the first few months, his biomarker rises, and he stayed on antifungal continuously because of the suspected fungal infection. Almost he had antifungals for 5 to 6 months. And once he became the our biomarker BDG negative here, for almost 5 months, he was off antifungal, and we just still kept him on fluconazole for his oral thrush. But as you see, at the end of his journey, he just get very high spike of beta D glucan, and that was when he was again started on dual antifungal. What I like to highlight here is that this patient has such a long PICU stay, but there must be some underlying immune deficiency process going on with this patient. And ultimately, at the end, he was diagnosed as a heterogeneous inherited bone marrow failure syndrome, which probably has contributed to multiple infections and no response to treatment. So in conclusion, ways to improve invasive fungal infection morbidity and mortality are the high degree of vigilance and knowledge of the risk factors and epidemiology, targeted antifungal prophylaxis, aggressive diagnostic approach, early diagnosis and early treatment, and right antifungal at right doses are very important. And we have to consider sometime immunomodulation in some group of the patient. And thank you very much.